We now move on to a highly engaging segment of today's program, a panel discussion. The topic for this session is expert opinion in obstetric anesthesia. We are privileged to have with us a distinguished panel comprising Dr. E.K. Ramdas, HOD, BMH, Calicut, Dr. Thomas P. George, Professor and HOD of Pushpagiri Institute of Medical Science, Tiruvalla, and Dr. Bala Bhaskar, Professor and HOD of BMCRC, Bellary. This session will be moderated by Dr. Sudheesh K.
ఫ్రంట్లో ఇటు చైర్ బ్యాక్ ఒకటి
It's indeed a great pleasure and honor to moderate this wonderful session where we definitely come across a lot of catastrophe in our anesthesia practice especially, and we do come across some near misses. So one of them, commonly what we notice is whenever we give spinal, sometimes the spinal might not act or it might act partially. Or sometimes another thing what we, dreaded situation what we come across is, you induce GI in a pregnant patient and suddenly you put a scope and you're not able to see anything. And the third situation is the same patient who throws seizures on the table as you are going to anesthetize. So these three are the important scenarios, and we have subject experts as well as panelists who are really experienced with their work in this field. So the first one would be to Dr. Bala Bhaskar sir. This is regarding a 32-year-old primary lady with a BMI of 42 and with preeclampsia and transverse lie who is posted for emergency LSCS. The spinous processes are very barely palpable, and still with great difficulty we administered spinal anesthetic. However, even after 5 minutes, there is some sort of heaviness in the limb, and the level of sensory blockade is only T11 at one side and T8 at the other side. So sort of very dicey situation, whether we have to continue or whether we have to go ahead with an alternative technique. So I request Bala Bhaskar sir to please elaborate on this particular situation as how he does this, handles the situation.
Take it back. Presentation. Good morning. Hello,
Sir.
Hello, good morning. Thank you, Dr. Sudheesh. It's, I think, strictly not a sort of panel discussion. We had some discussion among our own group, Ramdas sir and George sir and Sudheesh. So we decided that there are three different topics. Let us present our points of view, about 10 minutes each, and this session is for 45 minutes. Towards the last 15 minutes, probably we'll have discussion with our other experts in today's session. So that's how we'll take it forward. Okay. So thanks once again to the organizing committee, ISA Kerala, ISA Wayanad, Mupens College, Dr. Kama Devi. Thank you very much. So we have this situation which has been taken up for discussion. So what I thought was, if I am in private practice, just we had a private practitioner speaking about his experiences. So we initially feel little bit bored. Why something like this has happened? I have given spinal very perfectly, drug is given and it's not acting. We get confused. We'll be thinking about what should be done, basically. And we put on a sheepish smile. But of course, luckily we are all behind the mask. Okay. So, but we are not happy anyway that something like this has happened. This should not happen because, and it can also happen. To the extent possible, nothing is 100% proof in the world. Failures are always part of even anesthesia practice. So, if you look at the RCOA guidelines, they have indicated that in a elective cesarean section, not more than 1% should be a failure. If it is category 2 to 3 cesarean section, it should be below 5%, and it is category 1, up to 15% of failure is expected. Okay. Means failure has got different definitions. It is not that spinal anesthesia has not acted at all, but it is possible that failure would happen and we should be prepared for encountering some failures. For in the scenario just provided by Dr. Sudheesh, he said BMI is around 42, right. So, definitely I anticipate some difficult anatomy, palpating the intervertebral spaces. Whether it was given in a sitting position and lateral position, we do not know, but normally we prefer giving in a sitting position in an obese patient. That is but natural, because anatomically it is difficult to reach the space. And which space was used? Okay. Sometimes if it is, your patient is so obese, some space which is accessible, you would have just passed the needle. Whether it is L34 or L23 or it is L45 or L5S1, we will not know. But these also have got certain implications, and this is an emergency. Emergency means could be category 1, where by definition less than 30 minutes is available for establishment of anesthesia and to the incision time, and obstetrician is in a hurry, right, we are also tensed up. So, something like this has happened. So, these are the factors in the current scenario provided by Dr. Sudheesh. So, what I would do? So, before I go to the discussion points or some evidences which are available, what I would like to present before our group here is, for example, I will keep on monitoring I will not accept defeat at this point of time. So, what I will say, I will convince the obstetrician, just please wait for some more time, ma'am. I will say that probably it is acted, it is going to act little bit further, let us wait for few more minutes. So, not just the onset of analgesia or the dermatomal distribution, I will look at the blood pressure, I will look at the heart rate. Okay. Definitely, if there is a sympathetic blockade, if you have the next blood pressure reading, the BP would come down. If it is not going to progress, it is all based on my experience, and many of our colleagues would vouch for it. We do not have evidences, hard evidences for these, but as a matter of normal physiology of spinal anesthesia, we expect fall in blood pressure. We fall definitely, we think that heart rate would stabilize at least. Okay, if it is a laboring patient will have such a tachycardia normally if you have handled the cesarean sections 90, 96, 100, 110. So, that heart rate would also stabilize. So, that is the way we normally see, and gradually there could be an increase in depth of anesthesia in terms of sensory block and as well as motor block. And we are allowed to give little bit of head and down tilt, because normally we use hyperbaric solution, that is allowed. I am not going into the other discussion, it should not be doing and other things, but we can still do at this point of time. Okay. So, if it works, right, and I am confident as an attending anesthesiologist that it is progressing, I will allow the surgery to progress. I will just see that the patient is counseled a bit, I will counsel the patient that everything will be all right, and if necessary, I might administer gas oxygen 50-50 plus propofol. Possibly this is a preeclampsia case, maybe I will decide about ketofol considering other factors also. So, this is first option. But if I find that BP is still maintained or it is becoming more, tachycardia is still persisting and block is not deepening, conventionally by definition we are supposed to wait for 15 minutes to assess for complete onset of spinal anesthesia. So, whether I can afford to do that, whether the obstetrician or the patient's condition allows for us to do that, in a probably a preeclampsia patient that is left for the particular situation management. So, we can wait for 15 minutes, have the slight head and down tilt, and if there is no change at all, I can go for repeat spinal anesthesia as an option. It is not a rule, as an option. Again, conditions allowing, I can have a repeat spinal anesthesia. Then repeat spinal anesthesia would be whether I am going to give in sitting position, obviously because she is obese patient, and what volume I am going to use. I am not going to use the usual 10 milligrams. I am not going to use the 2 ml volume because there is some already residual blockade which is there. I might give between 1.4 to 1.6 ml, monitoring for definite risk of hypotension. Okay. So, this discussion will involve lot of comments and later on, but this is the way it is done. Okay, 1.2 1.5, but monitor the patient. This could be done, and if fentanyl had not been used in the previous dose, we can add fentanyl because fentanyl as an opioid, it will add to the quality of the block. At intraoperative block, missed segments all would not happen. No 15 minutes, obstetrician is in a real hurry. Okay, as an interregnum, in between we can administer fentanyl and propofol for the patient for preparation for general anesthesia with strict monitoring. Right. So, general anesthesia also it is very important for us to decide because we have to do it very fast. We should have been normally prepared otherwise to conduct general anesthesia. Already we would have given some supplemental analgesia or anxiolysis for the patient, and you should not have kept on giving fentanyl or midazolam or propofol or ketofol, and it creates such a huge cocktail. There is a risk of loss of airway reflexes and the patient getting unconscious. Patient may even regurgitate and vomit. Okay, so, we should be very careful while doing this, and if spinal has been given already after induction there is a risk of greater fall in blood pressure. So, this also you should be managing. So, this is the way I have expressed my way of management related to this case. Let us go for certain discussions. What is failed spinal anesthesia per se? Okay, from the time of Gaston Labert, it was what he told was you just insert a needle into the subarachnoid space, see the CSF coming out, administer the drug. The drug which you have chosen in terms of basicity, volume and the dose you administer, and the expected block does not happen in terms of the level of the block. So, for example, it could be followed by a repeat spinal, adding more sedation or conversion to general anesthesia. This is the definition which is normally used. In terms of stats, basically the failed spinal anesthesia based on this definition might happen in about 1 to 1.9% of patients requiring general anesthesia, and about 2.7 to 10.2% of patients needing repeat spinal anesthesia or additional sedation. Okay, these are the statistics available as of now for obstetric practice, but there are multiple other factors. Some of them are general, which are not under our control, or it is technique related and anatomy related. So, as we are discussing already, you should always counsel the patient, elicit patient cooperation, see that the needle is in the right place. Okay. Really our tip of the needle should go into the subarachnoid compartment, the CSF should issue out, it should not be anywhere in between. So, incorrect placement of the needle would also result in definitely a inadequate spinal anesthesia. So, multiple factors, I have put only about 14 factors, nearly about 20 to 25 factors have been possibly described to be associated with failed spinal in obstetric practice. Some of them are referred to as preoperative failure. Some of them are shown as intraoperative failure. Intraoperative failure is mainly referred to the surgical component. Preoperative failure is mainly referred to our technique and administration of spinal anesthesia. Easy, this is all of us accept. It has been found that pain during cesarean section is maximum during epidural anesthesia. Next highest is combined spinal and epidural, and minimal with subarachnoid anesthesia. So, this is the basic physiology all of us should keep in mind. But what about the other factors? Lower BMI, it is said a patient with low BMI is likely to have less intra-abdominal pressure, larger subarachnoid space volume, volume is more, and for the given dose failure is possible. Okay, this is one, but evidences are not totally in favor of this theory. And secondly, it is also related to the height. So, a standard dose, again this is a western standardization, we have to use that so called 10 milligram to 12 milligram for heights between 155 to 170 centimeters. So, there is we may have to escalate the dose depending upon the height of the patient. If you have not done that, then there is a risk of failure. And BMI per se, obese patient, it is not related to drug at all, it is probably related to our technique. We may not be able to reach the space and you would have struggled also, and some drug would have gone, some drug would have come out. Early gestational age or preterm, similar principle is expected. Basically, there is a small uterine size less aortocaval compression, and associated larger epidural space and subarachnoid space volume. Okay. So, something like this is more important for us to understand. It is the single most important factor affecting the block height and regression, the CSF volume in the lumbar region. It is said that both sensory block and the motor block are inversely related to this CSF volume. Okay. So, if somebody has got large CSF volume and you are giving a fixed dose of the drug, the effect will be less. Okay. Then there is a small volume, a normal dose, it will have an exaggerated effect. This is unexplained. Primiparity, it is said that there is a greater risk of failure in primiparous patients, and it has not been clearly explained why it happens, okay, even with some of the evidences. And urgency of surgery, this is part of the definition. So, I told you category 1, we have just washed and immediately we have not even done adequate perianesthetic evaluation, putting a needle, we are in a hurry while pushing something has gone outside, or the obstetrician has washed, he is in a hurry and he does not wait for the block to act also. So, where the blame lies, so definition has to be modified in terms of failure. Then lumbar puncture level, it is also supposed to be one of the most important ones. So, sometimes especially obese patient in our current scenario, we may not be able to find any actual vertebral levels. So, if we end up administering at L4 and L5 to S1, okay, it is more likely to be associated with failure as compared to administering in L23 and L34. Okay. So, in fact, if you see this illustration here, if you use a hyperbaric solution, so if you administer in the mid lumbar region, you can see on the left side, so the drug would shift to the right side to the most dependent part of the lumbar region and adequate depth of height of anesthesia would be obtained. If you go to L5S1 or L4L5, it is more likely to go towards the sacral dermatomes. It becomes too low a space to administer and definitely the height of the block would not be achieved. So, this is one thing probably all of us should keep in mind, never go restrict to L23 or L34, never go to L45 and down. And sitting again, so position is supposed to be, we encounter more failures as compared to the lateral position, as much as 5% failures as compared to right lateral position in pregnancy. This is from pregnancy. And again, they could not clearly define why and how. There are a lot of confounders related to obesity and anatomical issues. And local anesthetic dose. So, the standard dose all of us normally follow without an additive will be 10 milligrams, right. I hope all of us would agree on that point. So, if you add an additive, a lipophilic opioid like fentanyl or whatever, we may add it, bring it around 2.2 to 2.25 ml. Okay, that is an acceptable volume. Any volumes less than this on an average are supposed to be more likely to be associated with failures. So, lipophilic, of course, they say it is always better to add opioids because they add to the quality of the block, patchy block incidences and everything would come down intraoperatively. So, you have the correct volume plus opioids that would bring down the risk of failed spinal anesthesia. Then previous cesarean section, this is a very simple one, they have got some data. So, probably there is lot of scarring, okay, when you handle the tissues, it is said that more depth of block would be required. The normal depth which is achieved with spinal anesthesia may not be adequate for this purpose. Tubal ligation, again all of us would have experienced, they would have sutured the uterine wall, then go for the tubal ligation. It is a separate parasympathetic reflex is the dominated one, and if some obstetrician is quite slow, the block is also wearing off. So, at that point the patient would feel pain. Okay, surgical duration again definitely it counts. So, more the duration, more the risk of patient complaining of pain. So, I have got lot of evidences which I have collected, but for paucity of time I will not show, but they have used different definitions for failure. That is again a problem to come to some conclusion. So, this was a retrospective study of about 5,500 patients. They identified previous cesarean delivery and surgery duration as important ones. Then this was another systematic review where they identified the spinal anesthesia supplementation in terms of opioids was greatest in terms of failure. Then this was another one related to it is a prospective study. They had multiple outcomes studied. See, most important was they found during elective surgery, the failed spinal anesthesia was very less, 0.8%, and rate of conversion was highest in category 1, 20%. Okay, and they also tried to link it to BMI, the previous cesarean sections, and other things. Okay. So, are there any guidelines for managing the failed spinal anesthesia? We have the different professional bodies, about 1, 2, 3, 4 of them, the American group, that is the SOAP, and the British group, and our Indian group, plus Royal College of Anesthetists. But the most comprehensive guidelines have come from the French practice bulletin. It's a big one, big document. But only thing is, what they have written is basically about certain themes where they speak about prevention, communication, recognition, and response. And in fact, they also talk about screening and management, and especially interaction with the various other consultants and specialists. Right? And this is one point I picked up from there. I actually didn't know about this particular topic here from the French bulletin. So, normally we do try to pick up the sensory block, pin prick, touch with pain, cold, touch, and touch with the spray. Sensation to touch would be the most useful to assess anesthesia. Sensation to cold would be the most useful to assess analgesia, and they recommend a bilateral T6 dermatobal level evaluated with light touch plus a bilateral T3 higher level evaluated with cold, which confirms that it is the most effective block for cesarean section. So, this is a guideline from that group. Record keeping is very important. I am just to conclude, because if I have failed, and if it's not that I failed, if the spinal anesthesia has failed, the patient can go for a second cesarean section, third cesarean section. It is important that we document what has happened, so that subsequently when the patient undergoes the next cesarean section, a better approach would be taken up. So, thank you very much for the time.
Now we have another scenario. So we know that this patient, he gave spinal, but the spinal didn't act, and we end up giving GA. So here is a 32-year-old first-time mother with borderline obesity who's rushed to emergency LSCS due to fetal distress, and without any prior airway assessment problems under pre-anesthetic evaluation. But once you induce GA, we encounter difficulty in airway intubation, and we can see the entire oral cavity being swollen, and the view Cormac-Lehen being poor, and O2 level starts falling. So what would Dr. Ramdas sir would do? He would share his experiences and the mode of management of this patient.
Thank you, Dr. Sudheesh. Before I start, I would like to thank the organizers for having me here. This is a case scenario which I would like to highlight. A 32-year-old first-time mother with borderline obesity is rushed for emergency seizure due to fetal distress. She has no known airway problems. After induction of GA, general anesthesia, you encounter unexpected difficulty in intubating her. The airway is swollen, the view is poor, and oxygen levels start falling. This is a clinical scenario which I would like to highlight here. And this patient is desaturating, and what is the incidence of desaturation in a obstetric suite? What should be what is recorded, or what does the statistics say? So it is said the desaturation is 1 in 6, or 17% in the obstetric operating room. So this is quite high. This number is very high. And what so before I start with the clinical scenario, so the incidence of failed intubation is different. The incidence of failed intubation is 1 in 224. So let us take it as 1 in 200 in obese individuals with pregnancy, and this again is quite high. But we seldom give general anesthesia these days. We usually give you choose local regional anesthetic for an obstetric case, but quite often we land up with problems, and we need to have a general anesthetic for a given case. And there are various reasons for this failed intubation. The reasons are, number one, as Dr. Sudheesh was talking about, the physiological changes or challenges, anatomical, hormonal. I will not go into the details of those now. And of course, the aspiration risk which are involved in these patients. And lastly, more importantly, the time pressure. We are all tensed. There is a lot of cognitive load in the anesthetist because of the various factors involved, because of the fetal distress, maternal distress, obstetrician's distress, and all that will produce problems in making a decision at that time. So what do I do? It has failed. A postgraduate has called me to see the patient. I ran into the operation room, and you have a patient who has not been intubated, and what do I do? So the first thing is always call for help. That has been done, and what I would do is I will reoxygenate the patient. Reoxygenation is in two ways. You have to do both simultaneously. One is pre-oxygenate with a tight fitting mask with a flow of 10 liters per minute. That is one. Number two, put in a catheter bypassing the upper airway or the nasal prongs and run oxygen at 15 liters per minute. That is what is called as a peri-induction oxygenation. So two things has to go simultaneously, and therefore you have to have two oxygen source there. With one oxygen source you won't be able to give like this. So have two oxygen sources in the operation suite. So do this. That is very, very important, is to cover the apnea period. To prolong the apnea period, you need to have the reoxygenation properly. And number two, optimize position. By optimizing position, I mean that you should change the patient's position. Patient should be ramped up properly, or you should change the person who is intubating. You should change the blade. So there are several things to be done for doing the second attempt. You cannot repeat the same attempt. You will not succeed in doing so. So keep changing the whatever you want to change, and that is number two. And routinely, gentle ventilation is allowed as per the current recommendation by all guidelines. So gentle ventilation, but remember the gentle ventilation should never be more than 20 centimeters of water pressure. So gentle, that is what is meant by gentle ventilation. So ventilate the patient gently. At the same time, apply cricoid pressure. Cricoid pressure will prevent insufflation of the stomach, and also it is very important to have the cricoid pressure at the time of ventilation. And you should have a low threshold for releasing it whenever it is required. While intubating, you will find it difficult if the cricoid pressure is applied, and therefore one has to release it at the time of intubation. And definitely you will have to maintain adequate depth of anesthesia, because depth of this is a time when the patient becomes aware, and therefore you should have an extra load of propofol or thiophanate sodium, whatever you have used for induction on the workstation, so that you can give it once again. And attempt only if the SpO2 is more than 95%, 95 or above 95%. This is again one thing very good about the Indian Association Difficult Airway. The recommendation is you wait for the saturations to build up, and then it is not there in the DAS guidelines. And here you like to, if you have a video laryngoscope, it is a rescue scope which should be there in the obstetric operation rooms. Use a video laryngoscope. Ideally the D blade of the video laryngoscope, you must be trained to do that, and therefore use a video laryngoscope to re-intubate the patients. Now the tube is in, you cannot assume that the tube is in, you need to confirm the position of the tube. How do you confirm the position of the tube? There is only one method, that is a gold standard, that is by looking at the end-tidal carbon dioxide. It is not just looking at the value on the end-tidal carbon dioxide, but you need to look at 5 waves of EtCO2 without a decline, because if the carbon dioxide has gone into the stomach, you might find waves with decline, and that you can't take it as to confirm the proper placement of the tube. Now it has failed. You have again failed. I have failed in the re-intubation attempt, and then again start oxygenation of the patient. As I said, 15 liters and 10 liters by both methods, and you prepare for the second generation supraglottic airway device. Why did I say second generation supraglottic airway device? Because of 3 reasons. Number 1, the second generation has got a gastric vent. You can put in a gastric tube. Number 2, you can increase the ceiling pressure. The ceiling pressure has to be around 30 centimeters of water pressure. It should be more than the peak pressure of the patient. Look at the peak pressure. If it is 25, this should be at 30. The pressure in the ceiling pressure of the supraglottic airway device. So that will prevent again aspiration of the stomach contents into the lungs and allow maximum 2 attempts with graded cricoid. As we did the intubation with an endotracheal tube, you need to limit your attempts at 2 here also, and again maintain depth of anesthesia. So this has to be done systematically with a cricoid pressure, same as endotracheal tube, and then intubate the patient with the supraglottic airway device. If you have succeeded in doing this, you continue with the surgery. Don't meddle with it is not wise to meddle with the upper airway again, because the pregnant patient with edema of the upper airway. So continue. If it is only a Seizure, you continue and let the baby be out. So proceed with the delivery with a supraglottic airway device, continue anesthesia through the supraglottic airway device, and accept low but definite aspiration risk that we had to expect. There are several papers which I am not going to the details of those, showing that supraglottic airway can be used as a prime airway device in cesarean sessions. And after the delivery of the fetus, if the mother is having any problem like hemodynamic disturbance, bleed, or throwing out seizures, or if there is a very high risk of aspiration, and then one should consider intubating through the supraglottic airway device. Again, you cannot intubate through the supraglottic airway device without a fiber optic endoscope. You should be an experienced expert in using a fiber optic bronchoscopy. You cannot use it as your first choice. And therefore, also you should have ideally should have an Aintree, A-I-N-T-R-E-E-E, Aintree exchange catheter, which could can deliver oxygen with the exchange catheter. So ideally you should have it, and that is the way it should be done. So again, I am not going into those details here. So here you have failed here also. The supraglottic airway device has failed. You are not able to ventilate the patient. The edema is, the oral cavity is swollen. And what we do, we have to oxygenate the patient as before. Final face mask ventilation attempt. Use optimal technique. Again, change the position and try to do it. Employ airway adjuvants as needed, but when putting in a nasal adjuvant, be careful, it might bleed. Oropharyngeal, nasopharyngeal airways, and ensure adequate neuromuscular blockade before entered. If you had given hexamethonium, you may have to repeat hexamethonium. I always prefer hexamethonium because it is easy to calculate, 2 milligram per kilogram, 1.5 to 2 milligram per kilogram per body weight, and easy to give. Whereas those who use rocuronium, it can also be used. The calculation of dose could be sometimes difficult because you have to look at the lean body mass and all that. So easy to use, but it has got pros and cons. You may use either of these. And after that, that is very important to ensure adequate neuromuscular blockade. The old teaching is not to give muscle relaxant at all when you are in trouble, but here you need to give a neuromuscular blockade. And if face mask ventilation fails with all these maneuvers, then you call it as complete ventilation failure. This is a terminology which is used by the Indian Association of Difficult Airway. The DAS guidelines says CICO, cannot intubate, cannot oxygenate terminology, but I feel the complete ventilation failure is a better terminology, not because Dr. Ram Kumar is here sitting in front of me, because he is he has done a pivotal role in formulation and evaluation of this airway algorithm, Indian airway algorithm, which was, I think, was done in 2015. So I am a great fan of this Indian guidelines because several of the things are very practical and to our Indian standards, and some of the terminals are really good. So the last, when you have, it's very difficult to ventilate, even ventilate a patient. What we should do is cricothyroidotomy. That is again the Indians nomenclature what the Indians have used. The DAS says front of neck access, then so front of neck access we don't look very, it's not very, because we don't go back for a airway, and therefore this I would prefer a cricothyroidotomy for using that terminology. But if you had anticipated cricothyroidotomy pre-operatively, you would have marked the cricothyroid membrane. So it would have been easy. But in an emergency, it is difficult to find out cricothyroidotomy. So you should have always be watching at the cricothyroid membrane to do this procedure. For that, you need to have a second help, so that you have more physical and mental support from the second help. It may be a junior person or a senior experienced person, whatever. So call for additional help, continue oxygenation with nasal oxygenation, position for cricothyroidotomy, and choose a technique. There are 3 techniques explained: the scalpel technique, the whiteboard technique, and the needle technique. I prefer the scalpel technique. The whiteboard technique, that is the one anesthetists are more familiar with, but the needle technique, you need to have a jet ventilation. So without a jet ventilation, you won't be able to do anything. So choose a technique, choose a proper technique, ideal technique which you are familiar with, and perform the procedure. So once performing the procedure, the patient deteriorates. You don't wait for the baby to be delivered. Do a perimortem cesarean delivery and take out the baby. And then it will be easy to resuscitate the mother if the baby is out. So before we start, we should have a proper checklist, equipments. All the airway gadgets should be there in the obstetrics operation room. Difficult airway cart should be there. And of course, if there is a potential for difficulties arising, there should be a person at least outside the operation room to help you. Without that, you should not attempt general anesthetic in a obstetric theater. So that is not over. We have had a difficult airway now, then the extubation is more tricky here. You cannot leave the operation room. At the end of operation, you don't find anyone in the operation rooms. The helper might have gone. So this is more critical than the intubation time, equally difficult situation. So develop a planned extubation strategy before attempting to remove the endotracheal tube. And always remember, reintubation is very difficult. Consider every extubation as a potential reintubation, especially in a case of difficult airways. And also document properly, as we are all talking about documentation, or documentation is extremely important. So I will conclude with some of the things here which are very, very important. Number 1, ramping. Ramping is extremely important. There are several advantages to ramping. Number 1, it will improve the functional residual capacity, and therefore the pre-oxygenation would be better. Number 2, it will prevent the diaphragm going up because of the gravid uterus, and therefore the FRC will increase. Number 3, there is a theoretical advantage by having the head above the level of the stomach, and the gravity, by virtue of gravity, the regurgitation and aspiration would be far less. The second thing, the pre and apnea oxygenation. I will repeatedly tell you that 2 oxygen sources should be there, one at 10 liters, another at 15 liters, throughout the intubation trial. That will increase your apnea period. You can prolong it from 5 minutes to 10 minutes. And recently, what Dr. Sudheesh was telling, the high flow oxygen, nasal oxygen thing which has come, it's a fancy thing which has come now, that is being studied in the obstetric suite. If that is used, it can increase it to 20 to 30 minutes, but then there are more evidence has to come before you use that. That is the second thing. The third one is rapid sequence induction. So I have told you, people use hexamethonium or rocuronium, whatever you use. Rapid sequence induction is very important in the pregnant mothers. And you should always apply cricoid pressure, and gentle ventilation is always required. That is not there in the beginning guidelines, but gentle ventilation is recommended and to be used routinely. And the last one, you must have the ability to use confidently a video laryngoscope. So you have to use the conventional laryngoscope a few times to learn a video laryngoscope, and especially when you are practicing only in the obstetric suite, it becomes very difficult, to learn a laryngoscope, because seldom you do a general anesthetic in the obstetric suite. So you rarely find patients, being intubated in the obstetrics. So you need to learn a conventional method and then learn the video laryngoscope, and that would be the ideal way to intubate a patient when you find it difficult. So to finish, some key points of the All India Difficult Airway Association guidelines. So they have stressed some of the things which are very important, I feel. Oxygenation, the two things, to wait for 95%, that is only there in the Indian guidelines. Wait for 95%, don't escalate on your attempts without seeing this 95% mark. Number two, confirmation with 5 waveforms of the TCO2, that is again by the Indian Association. Limit attempts to 2 before proceeding to the next step. Don't go on repeating the attempt without looking at the SpO2. So that is the third thing. Just because they say 3 attempts, don't go on doing it. And the nasal oxygen, continuous nasal oxygen at 15 liters per minute to prolong apnea time. These are the few things which are there in the Indian Association's difficult airway algorithm. Okay, thank you.
We go on to the third scenario where a patient throws seizures on the table, a 42-year-old lady who's shifted onto the table for emergency LSCS, and she immediately throws seizure on the table. Dr. Thomas sir will elaborate on that. Dr. Bhaskar sir needs to catch a train now, so I think he will be leaving.
Thanks to Dr. Venu and Dr.
Dr. Bhaskar sir is leaving because he has to leave. So once he leaves, we'll continue the session.
I request Dr. Sudheesh to kindly felicitate Dr. Bala.
We shall continue the presentation now.
Thanks to Dr. Venu and Dr. Anjana. Yesterday, the topic was discussed in detail in eclampsia. All the problems were discussed in details. But I will say, when a seizure comes, you should diagnose seizure properly. Seizure is a transient disturbance in the cerebral function caused by abnormal, paroxysmal, hypersynchronous electrical neuronal activity in the cerebral cortex. What is your opinion? Seizure and epilepsy both are same? It is different. Seizure is a transient thing. If a multiple seizure occurs, then it becomes epilepsy. Okay, that is a basic difference. Now, there are different types of seizure, focal as well as generalized. Focal seizures are simple seizures, then complex partial or otherwise known as petit mal, then generalized seizures like absent seizures, atonic, myoclonic jerks, tonic, clonic, and the final one, generalized tonic-clonic or grand mal seizures. Now, when a seizure occurs, it goes through 3 different phases. Prodromal phase, that is where the patient impending doom, something is going to happen, patient will be alerted. Then ictal, that is the seizure occurs. Then post-ictal, where there is confusion and the patient has some headache. Now, these are the different causes of seizure as a whole. Starting from idiopathic infections like meningitis, encephalitis, brain injury like subarachnoid, subdural, or whatever the hemorrhages, then electrolyte, metabolic, withdrawal, that is alcohol and other things, toxins. Now comes stress, lack of sleep, and flashing lights. These are the three things we ignore. These are the three things can produce seizure. Then genetic causes and structural damages. Now, coming to specifically for OBG, these are the major causes of seizure in OBG, that is eclampsia, press, last, amniotic fluid embolism, subdural block, metabolic, and electrolytes. I will start from the lower upwards. Electrolytes, hyponatremia, hyperkalemia, hypo as well as hypercalcemia, hypomagnesemia, and hypophosphatemia. All this can produce seizure. So a simple ABG will reveal what is the electrolyte imbalance. Metabolic, apart from the inborn errors of metabolism, these are the conditions you should look. Hypoxia, hypercarbia, both metabolic as well as respiratory acidosis, also respiratory alkalosis, and most important, hypoglycemia. Then a subdural block. This is a newer thing. When you are giving a subarachnoid block, that is our usual spinal, you rotate the needle hub towards the cephalic direction. A part of the bevel comes out in the subdural space. It's a potentially narrow space. You inject the drug thinking that it is in the subarachnoid space. The drug gets into the subdural space, can produce subdural block. Another thing is, when you are putting a epidural needle, inadvertently you puncture the dura, CSF comes out, immediately you withdraw. Then again you inject air and see loss of resistance, and there is no CSF comes. You think that is in the epidural space, but there is a small chance that it is in the subdural space. You thread a catheter, the catheter may be in the subdural space. Now, when you inject drug in the subdural space, what are the signs and symptoms? It produces patchy block, it produces cardiac, that is high spinal like symptoms, and also it can produce convulsion. So beware of this condition. Here what you have to do is wait and some symptomatic management and care of the thing. Now, amniotic fluid embolism. Amniotic fluid embolism, where the fetal content and amniotic fluid comes into maternal side. It will get into the maternal bloodstream and produce problems. The first problem comes is acute right ventricular failure, which is followed by acute respiratory failure, which will later produce late left ventricular failure. Along with that, there is a high chance of hypovolemia, acute renal failure, and DIAC. So, amniotic fluid is embolism is a dreadful situation. You should act very quickly using inotropes, supportive measures, others. Then comes other cause of last, that is local anesthetic, systemic toxicity. The causes are when you inject a drug, local anesthetic drug, above the toxic level. Second thing is when you inject a drug into the intravascular space, or you inject a drug where the vascularity is more, that is not applicable here. Usually it is in the intrapleural, intercostal, epidural, followed by brachial plexus, followed by paravertebral space. This is the order at which the vascularity decrease. Now the treatment is ACLS protocol followed by lipid emulsion therapy, and also you have to go for the anticonvulsant. Now next condition is PRES, that is posterior reversible encephalopathy syndrome. PRES, even though it is called the posterior, it can also occur in the anterior part also. Commonly it is seen in the posterior. Even though it is, we say it is reversible, sometimes it is irreversible also. The diagnosis can be done by MRI, especially in T2 image where there will be hyperdense. As you can see here, in the flare you can see there is vasogenic edema is there. Now last and the condition here, that is eclampsia. I am not going into the details because already it is discussed yesterday. I will give a nutshell only. Pre-eclampsia plus seizure is, you call it as eclampsia. Pathophysiology, as discussed earlier, it is generalized vasospasm, which will produce increase in the hydrostatic pressure, allows the brain become edematous. When you are treating, you exclude help as DIC complications occurred or not. Management include ACLS protocol, antihypertensives, anticonvulsant, fluids, and magnesium. Magnesium, we have discussed Pritchard regime, which is based on the IM injection. Then Suspan injection based on IV injection. There is something called Kerala Federation of OG has come with mixing these together. Whichever thing is followed in your institution, kindly follow it. And while monitoring, you have to monitor the urine output, tendon reflex, that is deep tendon reflex, respiration, urine output should be more than 30, respiration more than 40, and SpO2 more than 94. And the serum levels of magnesium, always consider serum level of magnesium, they will give in 3 different methods, that is millimole per liter, milliequivalent per liter, and milligram per deciliter. Always getting confused. In ABG, in your ABG, what is the value? Accordingly, you study. In our institute, it is given as milliequivalent per liter. So it is 4 to 7 is therapeutic dose. More than 7 is loss of tendon reflex. More than 10 is loss of respiration. More than 25 is cardiac arrest. With that, I end. Thank you for allowing.
Being very succinct and brief in your presentation, and also giving those practical tips how to face a situation and manage the situation. So due to the paucity of time, if I would allow only 1 or 2 questions to each speaker with regards to the cases presented. Any questions?
Ramdas sir, I have a doubt. Can we use FOB in difficult airway? In difficult airway, can
you mean as a
unanticipated?
as a primary approach in a difficult airway in obstetrics?
Primary I failed. I failed when unanticipated difficult airway
In obstetrics.
Can I opt for FOB as a second opinion?
Only 2 things. One, availability and familiarity. If you're familiar, go ahead. I think it all depends upon. Hello, yeah. So if it's available and you're familiar, you should use it. Okay, otherwise you go for your 2nd generation supraglottic airway device. Right? I think the 2nd generation supraglottic, even supraglottic airway device as such has changed our practice. It has given us a nice fallback option when we fail intubation. So I think if your center is comfortable, you have the working fibroscope and you have expertise, that is your first choice.
By keeping the apneic oxygenation technique?
Yes.
Along with that,
Absolutely, absolutely, yeah. Since you brought up the apneic, I just add 1 point for the postgraduates, benefit. See, how many of you practice with anesthesia workstations? Right, so you know where the second source of oxygen comes from, right? Yes. But if you are working in a center where there is no second source of oxygen on your anesthesia machine, it's worthwhile getting a B-type cylinder in the operating room, like you have in the ward. It definitely helps in all patients, particularly obstetrics, because there are 2 lives involved. Okay, so you can just do that extra bit, get a B-type cylinder with an oxygen flow meter. That will be a second source of oxygen. Okay.
A lot of emphasis has been placed with regards to para-oxygenation. That is, earlier we used to think of pre-oxygenation, where we used to oxygenate and then go ahead with apnea without giving oxygen. But nowadays, the emphasis is lot on para-oxygenation, where we continue to oxygen even during our attempts of securing the airway in the form of LMA or in the form of intubation or use of fiber optic. So I think we'll have to, and that has been very well emphasized in most of our, especially our Indian guidelines. And even the guidelines, revised guidelines are coming very soon. Ramkumar sir, I think he will definitely tell about it. I mean, he will get that guidelines done in a probably very short time. And we are expecting a revision, and there is a lot of emphasis placed on para-oxygenation. So I think that is one take-home message we should always think of. Para-oxygenation definitely reduces the incidence of apnea, not only reduces the incidence of apnea, but also prolongs the duration of ventilation by its effect on, by the effect of mass effect. It does contribute to ventilation, not only oxygenation, but also to ventilation. And we have to adapt, it's always safer to adapt that para-oxygenation techniques, either in the form of nasal prongs or some sort of a second source of oxygen or use of HFNO. Some sort of oxygen supplementation should go on throughout the attempts at intubation. I think Ramdas also has emphasized that very strongly, and Ramkumar sir also has emphasized about it. Yes, yes sir. Yes, sure sir.
Yes, Ramdas, in the 2016 guidelines, 15-16 guidelines, we did talk about partial release of cricoid force. But now much literature has come after that. I believe we were wrong in recommending partial release. The next guideline is going to recommend complete release of cricoid force. And I think we have a session this afternoon by Dr. Pavitra. Yeah, you could be talking about cricoid force versus paratracheal force. So I'm sure you'll be emphasizing that this in your session. So that's, I think, one thing that I would like to say. It will definitely change in the next guideline, because we were also along the wrong track in 2015. A lot of information has come after that in the last 10 years. So now we recommend complete release, no partial release. So I just want to add that, Ramdas. You were right in saying the last guideline said that. Okay, and I remember my chief, the late Dr. Prabha Kangle from JIPMA, where I trained, and she used to say that cesarean section, the most senior person on duty should do the anesthetic. And those days, 9 out of 10 patients was GA. Okay, and I think that brings into focus the importance of failed intubation in obstetrics. I have lost no patient of obstetrics during intubation, but I have lost one patient during extubation. And thanks, I think, Ramdas, again, for emphasizing that. Intubation doesn't solve the whole story. You can land in trouble at extubation also. And the only obstetric case I have lost as a senior resident was at extubation due to regurgitation. And it always comes back as nightmares, right? So remember that intubation doesn't solve the issue. Proper extubation and change to a normal airway. Normal airway is equally important as intubation, right? That's it. Thank you. Lovely panel discussion, very well thought out cases, and I think the three of you did a brilliant job. Thank you.
So if there are no further questions, can we close the session? Thank you. I'd like to extend my heartfelt thanks to the entire team of anesthesia of Mupans Medical College, Akma Devi, and ISA Wayanad branch, as well as Kerala State branch, for having faith in me and handling over so many responsibilities to me, and hope I have matched up to the stage. Thank you so much, sir. And it's indeed a great pleasure to have Ramdas sir, Bhaskar sir, and Thomas sir on the stage and having interacted with them. It's been a great learning experience for me as well. Thank you so much.
Thank you, sir. Now I request Dr. Sudheesh to kindly felicitate Dr. E.K. Ramdas and Dr. Thomas P. George. Now, I request Dr. Kishore to kindly come to the stage to felicitate Dr. Sudheesh.